Great. So I'll just start the talk. So these are my conflicts of interest. I received research support from the Swiss Heart Foundation. So I'll just start by stating the obvious, and namely a symptom of gradual onset of irritative or positive type is considered to be characteristic of migraine aura, and vice versa. A symptom of sudden onset of deficit or negative type is considered of being characteristic of an ischemic brain event. The migraine aura symptoms, they are defined and characterized by the ICHD-3 criteria. Those are 4 criteria, A, B, C, and D. And I put here only the C criterion because it's the clinical criteria that basically tells the physician how a migraine aura symptom should be reported by the patient. So it has 6 points, 6 characteristics, one to 6, and 3 of those 6 points have to be fulfilled in order to have a fulfilled C criterion. So I'm sure you all know these. At least one aura symptom might might begin gradually over at least 5 minutes. 2 or more aura symptoms should occur in succession, that is one after the other. Each individual aura symptoms must last more than 5 minutes, but less than 60 minutes. At least one symptom must be unilateral, and at least one symptom must be positive, and the aura should be accompanied by headache within 60 minutes. However, we are clinical neurologists, and on the emergency department, we had patients who had symptoms, who had a stroke, who were diagnosed with ischemic stroke at the end, but had symptoms who were characteristic of migraine aura, like this young female patient. She had a numbness of the right hemibody with a sudden onset. So it was a negative symptom of a stroke-like symptom. So a negative type with a sudden onset. She also had a paresis and a dysarthria. However, the numbness occurred at first, and afterwards she reported the paresis and the dysarthria. And she had also no headache. And she had a stroke. For the example is this middle-aged man, male patient with a sensory disturbance. However, this time he had a mix of paresthesia and numbness, and the sensory disturbance wanders or spreaded from the right hand to the right side of the face to the right leg, and all that within 5 minutes. And the maximum intensity of the sensory disturbance was reached within 45 minutes, and after that it was persistent. And this patient also had a headache, and the headache was a migraine headache. So it was a one-sided stabbing with high intensity. It was worsened by movement and had all the meningeal irritative symptoms that migraine headache also does. So it had photophobia, phonophobia, and nausea. Also, the duration in this patient was characteristic for a migraine headache. And this patient also had a stroke, so a left dorsolateral thalamic stroke. So the question that we had after seeing this patient, it weren't only these two. There were more patients with migraine-like symptoms who had a stroke. And then the question that we had was how often does this phenomenon occur in ischemic stroke? And we performed a literature search, and we did not find much. So the first neurologist who reported this phenomenon was Charles Miller Fisher more than 50 years ago. Well, he was the first that stated the problem, and that is the fact that the clinical differentiation between a migraine aura and ischemic stroke is difficult. So it's a clinical problem for neurologists. Also, he was the first to report the fact that the paresthetic march might occur in ischemic stroke, and he describes also the vice versa. So the fact that patients with migraine aura might have stroke-like symptoms. So symptoms with no march, symptoms that reach the peak immediately, and negative, also purely negative visual symptoms. I very much like to put the text of the manuscript because I find it very impressive that he back then was able to recognize such a fundamental clinical phenomenon. And well, after Charles Miller Fisher, there were not many reports describing this phenomenon. So there is a seminal work by Jes Olesen, published in '93 in Brain. It's basically a case series of patients with ischemic stroke whose symptoms were very similar to a migraine aura. Then there is the more recent report by Waters and Kleinig from Australia, and they present the same phenomenon. And then there is the small case series of Koch and colleagues from Los Angeles who report the same phenomenon. However, they included also patients with TIA. The first two case series had patients with confirmed ischemic stroke. So bottom line, there was not much data on this matter, and we could not answer the question that we had, how often this phenomenon occurs in ischemic stroke. And this prompted us to perform a study to answer this question. So we asked patients, we asked patients with stroke and patients with migraine about their symptoms. And we included a fairly large number of patients with ischemic stroke. And for this study that we performed, it was really important that the ischemic stroke was confirmed by imaging, because we had to be sure that the symptoms of the patients might be attributed to the ischemic event. We also included 343 patients with migraine with aura, and the migraine with aura had to be a definite one according to the ICHD criteria. Obviously, with regard to the patients with stroke, we had to exclude patients, or at least for the first analysis, to exclude patients who had a wake-up stroke because they could not remember how the symptoms began. We could not perform an interview study with patients who had cognitive deficits, who had, for example, aphasia or had dementia. We obviously had to exclude those patients. Consequently, patients with more severe stroke were also excluded because they tended to have more cognitive deficits. We created a questionnaire, and the questionnaire had questions based on the C criterion of the ICHD-3 classification, because as I said, those questions define, those criteria define a migraine symptom. So we asked the patient about the symptom type, the symptom duration, how the symptom began, whether it was gradually or gradual or sudden. We asked the patient whether they had more than one symptoms and whether the symptoms occurred in succession. And we asked them whether they had headache within 60 minutes of symptom onset. But as expected, patients with stroke were older, and they had a mean age of 71. Patients with migraine were younger. Then, as mentioned, we could include only patients, or mostly patients with minor strokes, because those with severe stroke, they had more cognitive deficits, or had more medical complications that precluded the use of a useful interview. There were more men in the stroke group, more women in the migraine group. And in this kind of studies, the recall bias is really important. It's an aspect that had to be considered. And therefore we asked the patient with ischemic stroke fairly soon after the stroke happened, in order for the patient not to forget how the symptoms were. And the median day after the stroke was of the interview after the stroke was 2 days, and the migraine group was interviewed roughly a month after the last migraine aura happened. But we did not see this as a big problem, because patients with migraine, they experience a migraine multiple times during their lifetimes, so it's less likely that they forget how the aura were. So these are the results. It is a number heavy slide, but I'll try to highlight the most important results. So patients with ischemic stroke and visual symptoms reported positive symptoms only in 32%. Negative symptoms only in patients with migraine, aura, and visual symptoms have been reported in 12% of patients. And the mix of positive and negative symptoms have been reported by 14% of patients with stroke and 21% of patients with migraine. And the overlap of the symptom type is presented in the graph here on the right top side. Moving of the visual symptoms over the visual field has been reported by 21% of patients with stroke and visual symptoms, by half of patients with migraine aura. A sudden onset of visual symptoms was reported by roughly a third of patients with migraine aura, and a gradual onset of visual symptoms by a quarter, so 24% of patients with ischemic stroke. And again, the overlap of symptoms is presented in the right bottom graph. With regard to the sensory symptoms, positive symptoms only have been reported by 35% of patients with ischemic stroke, and the negative symptoms only by 31% of patients with migraine aura, and the mix of positive and negative symptoms by 19% of patients with stroke and 44% of patients with aura. The overlap of symptoms in case of sensory symptoms is larger and compared with the visual symptoms. And the spreading of symptoms from sensory symptoms from one part of the body to another was reported by a quarter of patients with stroke and by a majority, by 61% of patients with aura. The gradual onset of sensory symptoms has been reported by 24% of patients, so roughly a quarter of patients with ischemic stroke and sensory symptoms, and the sudden onset of sensory symptoms by a fifth, 20% of patients with migraine with aura. With regard to paresis, a sudden onset has been reported by 28% of patients with aura, and a slowly occurring onset by 22% of patients with ischemic stroke. And interestingly, spreading from one part to another one part of the body to another of motor symptoms has been reported by 19% of patients with stroke. We asked also, as mentioned, whether patients had symptoms that occurred in succession, and in those patients with more than one symptoms, 58% of stroke patients reported symptoms that occurred one after another, and as expected, most of patients with migraine aura did. So before I go any further, I must say that we performed all kinds of comparisons, and we have seen that obviously more patients with ischemic stroke have stroke-like symptoms, and more patients with migraine with aura have migraine-like symptoms. So it's not to say that migraine aura symptoms are more prevalent in ischemic stroke than the classical stroke symptoms. However, what we found was that the overlap of symptoms in both groups is large, and this puts us physicians, as clinical neurologists, in a very difficult position, because in an individual patient, the differentiation between migraine aura and ischemic stroke based on the history of symptoms alone might be very difficult or even impossible. And this is we were very delighted to read this recent study published in Stroke by Whiteley, who confirms our study. So they basically put neurologists, they asked neurologists to diagnose a patient based on the history and clinical examination, blinded to the MRI results. So they found that 11% of patients who were clinically diagnosed with migraine with aura, there was an ischemic in MRI. There was proof of acute ischemic lesion. So they had basically an ischemic stroke. So the question that we had next was why? Why do so many patients report migraine-like symptoms? And the first and obvious answer would be the cortical spreading depolarization. We all know the spreading depolarization is thought to be the pathophysiological basis of migraine aura. It is a wave of slowly occurring depolarization within the brain tissue, and it explains all the symptoms of migraine with aura. However, it has been the spreading depolarization has been found also in ischemic stroke. In experimental mice, they induced this wave by injecting microemboli. Interestingly, the microemboli do not have to cause an overt ischemia to cause spreading depolarization. Obviously, there is also the situation of ischemic stroke with a large penumbra, and in this case, probably the patients have more stroke-like classical symptoms, because the depolarization would occur in non-functional tissue. These are the most cited and most known works on this matter. So the Nakamura was the first one to report spreading the polarization in humans in vivo. So here he describes a case report of a patient who had a middle malignant cerebral stroke in the middle cerebral artery, and it was a malignant stroke. And the patient underwent craniectomy, and he had also electrocorticography electrodes implanted, and like this he could find the CSD. In humans, Nozzari is the work by Nozzari and colleagues report experimental results in mice where they injected the emboli, and where they found that the spreading the polarization might occur also without an overt ischemic lesion. And Domen and colleagues reported, they made a big study with many patients with malignant ischemic stroke with craniectomy, and they found that spreading the polarization occurs in stroke with high incidence. Another explanation would be thrombus migration. In stroke, it's a phenomenon that has been well described. For example, this patient, I took it from the paper by Koge and colleagues. This patient had initially an ICA occlusion on the right side, and he had a small DVI lesion, and after a couple of hours he worsened, and they repeated the MRI, and they found that the ICA was this time open, but the MCA was closed, and the patient had a larger stroke at this time. This phenomenon of thrombus migration has been investigated in the recent study by Koch and colleagues. So they included patients who were candidates for thrombectomy. They looked at the MRA, MR angiography, and they located the thrombus. And after that, they looked at the image of the DSA during the thrombectomy, and they compared basically the location of the thrombus in the initial MRA with the location in the DSA, and they found that the thrombus migration occurred in about 1/4 of patients with stroke who underwent thrombectomy. So this phenomenon is not rare in stroke. A third mechanism that we could thought of was the collateral failing. So if an ischemic stroke happens, then an occlusion occurs, and then that leads to open to collaterals opening, and these collaterals, they fail. They fail invariably. So the rate in which they fail differs from patient to patient, but they go away. So this leads to a gradual increasing of the ischemic brain lesion, and this might also lead, at least in theory, to a gradually increasing of the intensity of the patient's symptoms. And the fourth mechanism would be this inhibition phenomena, and this is clearly depicted by this case published in Neurology in 2005 by Flint and colleagues. So they describe a patient with an occipital infarction, occipital stroke on the left side. The patient had hemianopia on the right side, and within the hemianopic field, the patient described visual hallucination. And this case report depicts a phenomenon that probably occurs more often than we think, and that is that certain brain regions act inhibitory. So they have an inhibitory action on other brain regions. So when those brain regions, the inhibitory ones, are affected by the stroke, then a release phenomenon or this inhibitory phenomenon happens, and then the patient might report positive phenomenon. And this might be then mistaken by this might be interpreted as a migraine aura symptoms. Well, further, we look within the stroke group, how many patients in how many patients the ICHD C criterion was fulfilled, just to have an idea how those patients with migraine-like symptoms differ from patients with classical symptoms, with stroke symptoms. And we found that patients with migraine-like symptoms were younger, were significantly younger. They were, at least in our center, they were least likely to be referred by the general practitioner. And this reflects probably the fact that the general practitioners are not aware of the fact that the migraine-like symptoms might be the expression of an ischemic stroke. Interestingly, the rate of self-referral was similar between patients with migraine-like strokes and patients with classic strokes, and this suggests the fact that for the patient, both types of symptoms are equally scary, and both types of symptoms drives them to self-referral, so bring them to us. As expected, patients with a comorbid migraine with aura had more often migraine-like strokes. And patients with a stroke within the MCA territory were less likely to have migraine-like strokes, and patients with stroke in the PCA territory, including diencephalon because of the P1 territory, patients with PCA strokes were more likely to report migraine-like symptoms. There was a trend towards less cardiac embolism. However, it was not significant, and obviously there was more PFO, probably driven by the comorbid migraine with aura. So now I'll talk about the never-ending question on whether patients with migraine with aura who present to the emergency department with a changed aura has a stroke or has just another aura. And in order to tackle this question, we had to answer whether an aura is stereotypical or not, because if an aura would be stereotypical in all patients, then every change of aura should prompt a suspicion of ischemic stroke. However, sadly, it is not this way. Michele Viana is a headache specialist. He investigated this question, so he asked patients with migraine with aura to note the characteristics of the aura during 3 consecutive attacks, and he found out that more than half of patients reported a non-stereotypical aura during the 3 attacks. And then the question is, how do we differentiate a non-stereotypical aura in a patient with migraine with aura from an ischemic stroke, because they most probably also an ischemic stroke would be different than a typical aura of that patient. So within our stroke, our study population that I presented earlier, we identified 17 patients who had a migraine aura, but who also had an acute ischemic stroke. And we found that the stroke was different in all patients, was different than the usual aura in all patients. However, alarmingly, the symptoms of ischemic stroke fulfilled the ICHD-3C criterion in 3/4 of patients. So that means that based on the history of symptoms in a patient with migraine with aura, in 3/4, it is impossible to say whether the symptoms of stroke correspond to an ischemic event or are just another different aura. However, we did find some red flags, some characteristics from the history that might help differentiate the stroke from an atypical, non-stereotypical aura. Or half of patients had at least one. Half of patients reported that the symptom that was present during the aura was absent during the ischemic stroke. 3/4 of patients had new focal neurological symptoms during their strokes compared to the habitual aura. The 59% of 10 patients reported that there was a change of the first occurring focal neurological symptom, and this time was sensory of mostly visual symptoms. The type of symptoms was reported by 41% of patients, and obviously there was a change of time dynamics. So the symptom duration, the symptom onset, has changed in about 1/3 of patients with aura during the ischemic stroke. And the aspect of headache, I think it's important to discuss because it's remarkable. So 40% of patients with migraine aura who had headache during their migraine aura did not have a headache during the stroke, and this is in contrast with absence of headache in the general migraine aura population, which is about 7 to 9%. In our study, it was 7, and Michele Viana reports an absence of headache in 9% of his study population. Well, until now, I described how we are limited with a clinical method in differentiating stroke from migraine aura. We looked at biomarkers in MRI, which might be helpful, and we specifically investigated the index vein. The index vein is a dilated vein in an area of the brain that explains the patient's symptoms, and it has been described as a sign, as a specific sign for migraine aura. And well, the definition implies also that the patient is not allowed to have a stroke, at least on imaging. So a DVI lesion is not allowed, and also an occlusion, a vessel occlusion is not allowed. So we looked how often this sign occurs in patients with stroke, epileptic seizures, control, and migraine aura, and found that it was significantly more frequent in patients with migraine with aura. We calculated the specificity of 97% of this sign, specificity for the diagnosis of migraine aura, and the positive predictive value was 70%. So the question for future research, the most important question, is how to identify patients with migraine-like symptoms with negative neuroimaging who are at risk. So how to identify those patients with migraine-like symptoms whose symptoms have an ischemic origin, because as I showed, the symptom is the type of symptom is not specific, and it just cannot be used as an argument against an ischemic origin. So this question, I am aware of the study group led by Peter Rothwell and Maria Tuna, who probably they will publish some results on this matter soon. Maria Tuna published a paper in Lancet, the non-consensus TIA paper, where she writes in the method section that patients with migraine-like symptoms and negative neuroimaging will be described in a later paper. So I'm really anxious to read their results. So that's it. Now these are the professors that they're supervising me at my hospital. So Christoph Schankin is the headache specialist. Simon Jung is stroke specialist, and Heinrich Matle, well, he's now retired, but his inputs always added value to our research. So thank you.